Hi everyone, welcome to the channel. I welcome you all and let's simplify medicine because medicine is not difficult at all. The only important thing required is that you should be willing to understand the things in the most logical way and in the most integrated fashion so that you are able to understand the concepts. I can 100% guarantee you that if you have understood the concepts, things are going to be very easy for you. Now, the topic for the day today happens to be the importance of knowing about the clinical concept of coagulation cascade. Coagulation cascade is a very importantly tested topic in the exams also, and it is a very important thing that you are going to be observing in your patients in the hospital. So let us start with the basics of coagulation cascade. What is the importance of the coagulation cascade and how is this coagulation cascade going to work? Please understand that whenever we are suffering from any kind of an injury, the individual is going to bleed. Now, whenever we are having any kind of a bleeding, after having the injury, we want the clotting to take place, and this clotting is going to be seen only because of activation of coagulation cascade. There are two mechanisms by which this particular pathway is going to result in the formation of a blood clot. Let's try to understand this particular pathway with the help of the important diagram. So coagulation cascade, friends, is going to get activated by two pathways. One pathway which is given the name of intrinsic pathway and the second pathway which is given the name of extrinsic pathway. Whether we are talking about intrinsic pathway or we are talking about extrinsic pathway, ultimately both of them have a common function. They will result in the formation of a fibrin clot. Let us understand how is the activation of the coagulation cascade going to take place. If I'm paying attention to the first pathway, that is going to be the extrinsic pathway. In the extrinsic pathway, during the time of injury or trauma, there will be release of a factor which is going to be given the name of tissue factor. So you can easily remember T for trauma, and T for trauma is going to be responsible for causing release of tissue factor from the damaged cells. This tissue factor is going to be responsible for causing activation of a coagulation factor, which is clotting factor number 7. So tissue factor is responsible for activation of factor 7. That is why I have written over here 7A. A means activated. Now this factor 7, when it comes in contact with the tissue factor, is going to be responsible for causing conversion of factor 10 to its activated state. So factor 10, which is normally present in the inactive form, will now get converted into its activated form, that is factor 10A. This factor 10, with the help of factor 5 and calcium, is responsible for the conversion of prothrombin into thrombin. The thrombin is now responsible for causing conversion of fibrinogen into fibrin. And this fibrin is going to be responsible for the formation of a clot. Whenever we are going to be talking about formation of a clot, we will require the formation of a stable clot, that means strong clot. Initially, when there is a deposition of fibrin, the clot that is produced is weak. But when we have the role of factor 13 over here, factor 13 is going to be responsible for making the clot stable, and it is going to be responsible for the formation of a strong clot. So we understand the fact that factor 13 over in the coagulation cascade is a very lucky factor. Otherwise, in some of the cultures or philosophies, people consider factor 13 as unlucky. But in coagulation cascade, please remember factor 13 is very lucky. So if I look at the pathway again, I want you to understand in the extrinsic pathway, presence of any kind of a trauma is responsible for the release of tissue factor. Tissue factor is responsible for activation of factor number 7. Factor number 7 is going to be responsible for causing activation of factor 10. Factor 10 causes activation of factor 2, that is prothrombin into thrombin. And this thrombin is responsible for formation of fibrin, that is factor 1. Factor 1 in the presence of factor 13 is responsible for the formation of a stable or a strong clot. That is what we need to understand. If I am looking at the intrinsic pathway, what will activate my intrinsic pathway? My intrinsic pathway is going to get activated because of the damage at the level of the blood vessels. Now, when we have a damage at the level of the blood vessels, there is going to be exposure to collagen. And this collagen is going to be an example of a negatively charged molecule. The negatively charged molecule is responsible for causing activation of factor 12. So, there is going to be activation of factor 12. Now, it is going to become activated factor 12. This factor 12 is now causing activation of factor 11. That is what you see over here in the diagram, friends. And once you are going to be having activation of factor 11, we will then have activation of factor 9. Factor 9 is then going to be responsible for causing activation of, with the help of factor 8, it is going to be responsible for causing activation of factor 10 again. So from 9, with the help of 8, you are having the activation of factor 10 over here. Please understand, once you are having the activation of factor 10, again the same story. With the help of calcium, with the help of factor 5, you are going to be having a conversion of prothrombin into thrombin. You are going to be having then conversion of fibrinogen into fibrin. And this fibrin is responsible for the formation of an initial weak clot. What will going to be making the clot strong? Yes, you are right. The lucky factor, which was factor 13, that is going to make the clot strong. So what do we learn in the intrinsic pathway? We learn that whenever there is an injury to the blood vessels, this is going to be responsible for causing activation of factor 12, then factor 11, then factor 9. Then with the help of factor 8, we are getting the activation of factor 10. After 10, we are getting the activation of factor 2. Then we are having the activation of factor 1. And ultimately, we are going to be having the formation of a strong clot in the presence of clotting factor number 13. So these clotting factors, which are actually protein molecules, which are very, very important because they get activated in a particular sequence, so that ultimately the point is whether we are talking about the intrinsic pathway or the extrinsic pathway, ultimately both the pathways come together for the activation of factor 10. And this factor 10 is now responsible for the formation of thrombin. The thrombin is now responsible for the formation of fibrin. And this is how the formation of a fibrin clot is going to take place. Right? Now, the importance of knowing about the formation of a strong fibrin clot is that at the time of injury, whether it is because of the damage to the tissues or because of damage to the blood vessels, we want the bleeding to take place only in a controlled fashion. We do not want excessive bleeding to take place. That is why the formation of a fibrin clot becomes very, very important. Right? Now, what is going to be the importance of knowing about this kind of a fact? We understand the fact that majority of these clotting factors, please remember, are going to be produced inside liver. Liver, you remember, is a source of most of the proteins inside the body. So clotting factors are also going to be produced inside liver. Second thing that you need to remember is for the formation of some clotting factors, we require vitamin K. Right? How do I remember this? I remember for the formation of a proper clot, K for clot, I am deliberately misspelling it. But I want you to remember for the formation of a proper clot, we are going to be requiring vitamin K. And vitamin K is going to be required for the activation of certain types of clotting factors. Now, which factors are going to be requiring vitamin K for their activity? The factors which are going to be requiring vitamin K for their activity are factors 2, factors 7, factor 9 and factor 10. So, please understand that these clotting factors are given the name of the vitamin K dependent clotting factors. They are called as vitamin K dependent clotting factors, factors 2, 7, 9 and 10. What is the importance? This factor 2, 7, 9 and 10, for their activation, they require a gamma carboxylation reaction. And for that gamma carboxylation reaction to take place, we have a very, very important role that is being played by vitamin K. So vitamin K is required for clot formation, and these factors are going to be given the name of vitamin K dependent clotting factors. If you observe carefully, what you will notice over here is that for the formation of a proper clot, we are going to be requiring the presence of a particular element or a particular cation. What is the cation I'm talking about? I said cation, and that cation happens to be calcium. So calcium is something which is very, very important as an element which is required for the clot formation. Clot formation, coagulation, calcium. That is how you can remember it easily. Why is it important? For the simple reason that this calcium which is required for the clot formation is ionized calcium. If I'm talking about ionized calcium, please remember the ionized calcium is going to be coming from the bones. So, majority of the clotting factors are being produced in which organ? The answer is very clear, liver. But which clotting factor is going to be not coming from the liver? That is calcium. And this calcium is what is also given the name of clotting factor number 4. Which vitamin is required for clot formation? Of course, we are aware it is vitamin K. Which clotting factors are going to be required for dependence in vitamin K? The vitamin K dependent clotting factors are 2, 7, 9 and 10. Now, this particular thing is important because some people are not as lucky as you and me. So friends, we need to understand the fact that some people who are going to be having deficiency of the clotting factors are going to be having a problem in the proper clot formation. If there is any problem in the formation of a proper clot, what will happen to the chance of bleeding? Yes, you are very right. If clot formation is not going to take place, the chances of bleeding is going to increase. So these conditions are what we are discussing subsequently. They are called as bleeding disorders or hemophilia disorders. I hope that the concept of activation of extrinsic pathway and intrinsic pathway is clear to most of you. Now, whenever we are talking about the coagulation cascade, we must understand that we have to monitor the activity of the intrinsic and the extrinsic pathway. So we are going to be having different types of parameters which are being done as laboratory tests by which we see for the activity of the intrinsic pathway and extrinsic pathway. Kindly look at the pathways and I want you to understand it very clearly. Extrinsic pathway is this pathway. Intrinsic pathway is this longer pathway. Both of them are coming together. This is what is going to be given the name of the common pathway. So whenever we are talking about the laboratory parameters by which we can monitor the intrinsic and the extrinsic pathway, we are going to be having two important names that we talk about for the testing of the clotting pathway. These two parameters are given the name of, one is given the name of prothrombin time, that is also called as PT, and the second one is given the name of activated partial thromboplastin time. Activated partial thromboplastin time, A for activated, P for partial, T for thromboplastin, T for time. So this is given the name of APTT. So APTT means activated partial thromboplastin time and PT means prothrombin time. They are different parameters which are useful for testing of different pathways of the coagulation cascade. When we are talking about the prothrombin time is going to test the activity of the extrinsic pathway and the common pathway. So what was the factor involved in the extrinsic pathway? Yes, you know it. Extrinsic pathway is going to be having the presence of factor 7. What are the factors involved in the common pathway? They are factor 10. They include factor 2, factor 5 and factor 1. So that is exactly what is written over here, that PT test evaluates the functioning of clotting factors like factor 7, factor 10, factor 2 and factor 1, that is fibrinogen. On the other hand, when we are talking about the intrinsic pathway is being tested with the help of APTT. APTT is activated partial thromboplastin time. It is used to evaluate the factors which are involved in the intrinsic pathway. What are the factors involved in intrinsic pathway? Yes, you are right. Factor 12, then factor 11, then factor 9, factor 8, factor 10, 5, 2 and factor 1. So if you understand, APTT is for intrinsic and common pathway and PT is for extrinsic and common pathway. Normally, if I'm talking about the value of PT and APTT, the value of prothrombin time is about 12 to 16 seconds. Now, this is very, very useful because this is exactly the value that you'll be using in your clinics when you are going to be looking at a patient who's going to be having a bleeding disorder. So, if you know the normal value, only then you can understand that the patient can be having a deranged value or abnormal value at times. So, prothrombin time is going to be having a value of around 12 to 16 seconds, whereas APTT is going to be having a value of around 26 to 36 seconds. What is the importance? The importance is what you need to remember over here. Whenever my patient is having a problem in, let us say, factor 7, then which pathway will be affected? Factor 7 means my patient is having a problem in the extrinsic pathway. So prothrombin time value is going to increase in such patients. My patient is having a deficiency of factor 7, so he will take more time for the clot formation to form and therefore the prothrombin time value is going to increase. On the other hand, if my patient is going to be having a problem in the clotting factors like factors 12, 11, 9 or 8, there is a problem in the intrinsic pathway, so the value of APTT is going to increase. Now, important thing that we need to remember over here is, how are we going to be remembering that which particular test of clotting pathway is going to be useful for which particular pathway? The name of the test and the name of the pathway, they should be in sync. You should be able to memorize them from the perspective of the exams, and that's very, very important. So please understand the fact, whenever we're going to be talking about PT is going to be remembering by the fact that you are going to be playing tennis. And when you play tennis, of course, you have to go outside. So tennis has to be played as it is an example of an external or extrinsic sport. So extrinsic pathway is monitored with the help of PT. It is monitored with the help of PT. Please remember this image as a pictorial memory so that you are able to recall it at the time of any kind of a discussion that you're having in your clinic. So playing tennis means that you have to go out in the ground. That means there is an extrinsic game and therefore it is useful for extrinsic pathway. On the other hand, sometimes the weather is not so good. So sometimes it is going to be raining. Then you have to play indoor games. And one of my personal favorite indoor games used to be table tennis. So when I'm talking about playing table tennis, it's an example of an indoor or intrinsic game. So APTT is useful for monitoring of intrinsic pathway. So whenever you're thinking in terms of playing tennis, you are going outside. So that means monitoring of extrinsic pathway. Whenever you're talking about playing table tennis, it is useful for monitoring of the intrinsic pathway. Once you know extrinsic pathway is useful for monitoring of factor 7 automatically, prothrombin time is useful for monitoring of factor 7, and whenever we are talking about activated partial thromboplastin time, it is useful for monitoring of factors like factors 12, 11, 9 and factor 8. So have that particular image in your mind, which is going to be helping you in understanding and taking care of so many of your patients. Now, whenever we're going to be talking about the other important thing about this particular pathway, there are people who are going to be suffering from what we call by the name of bleeding disorders. Such conditions are going to be commonly given the name of hemophilias. Normally, please understand what is happening. Normally, whenever there is going to be a blood vessel damage, normally in individuals without having hemophilias, whenever there is a blood vessel damage, the individuals are going to be having initially a bleeding, but the blood clot is going to be produced, and that is because of the activity of clotting factors as well as platelets. So bleeding is going to stop. This bleeding is going to stop. In people who are going to be having hemophilia, there is a deficiency of clotting factors. If there is a deficiency of clotting factors, it is easy for you to understand, friends, that whenever there is going to be a blood vessel damage, initially they will also bleed. But because they are having a deficiency of the clotting factors, so what will happen? Proper clot formation cannot take place. If proper clot formation cannot take place, they are going to be having inability to form clots. So these patients are going to be having excessive bleeding. And that is why these patients are going to be having the clinical features because of excessive bleeding. Let me just help you understand the fact. In patients having hemophilia, classically these patients are going to be having a history of a fall or a trauma, because of which they are going to be having too much of bleeding. And classically this bleeding takes place in their muscles, in their joints, in their deep tissues, or sometimes in their skin as well. So these patients are going to be having a problem that they will be having too much of bleeding. Now, whenever we're going to be talking about hemophilias, we need to remember that there are three important types of hemophilias which are commonly tested in our exams. These hemophilias are respectively called by the alphabetical order as hemophilia A, hemophilia B and hemophilia C. Now, what is interesting for you to note is that hemophilia A actually is going to be the most common type of hemophilia. It's the most common type of hemophilia. So that is what you are being asked as a question in the exam as well. And as we understand it very easily, so I can help you remember the fact A more than B more than C. This is the exact order of hemophilia. Hemophilia A is most common. Hemophilia B is less common than hemophilia A. And hemophilia C is out of the three hemophilias the rarest. Now, why is the patient going to be having hemophilia A? These patients are going to be having a deficiency of specifically clotting factor number 8. So whenever you're going to be writing hemophilia 8, you can write it as 8, or I can say that hemophilia 8 can be written as EIGHT 8, or I can write it as 8. So whenever you say phonetically 2 or 3 times, say 8, 8, 8. So there is always a sound of A over here. So whenever there is a deficiency of factor 8, you will be reminded of hemophilia A. That is what is to be remembered as. A is the first alphabet. A is number 1. It is the most common number 1 type of hemophilia. So two tricks that you understand now. Hemophilia 8 is going to be caused because of factor 8. And hemophilia A means first alphabet. First means number 1, most common. It is the most common type of hemophilia that is seen in your patients. Whenever I'm going to be talking about hemophilia B. Hemophilia B is going to be reminding you of factor 9. Hemophilia B is what is going to be reminding you of factor 9 deficiency. Whenever I'm talking about hemophilia C is going to be because of deficiency of factor number 11. Now, what is interesting for you to remember over here is that whether it is hemophilia A or it is hemophilia B or hemophilia C, there is a problem of factor 8, factor 9 or factor 11 respectively. And interestingly, all these factors are present in the same pathway. What was the pathway that we were talking about? They are present in the same pathway, which means they are present in the intrinsic pathway. So any of my patients who is going to be having hemophilia A or hemophilia B or hemophilia C, he will be having increase in the value of which parameter, friends? Will it be PT or will it be APTT? Yes, you know it very well. I want you to answer that question. Yes, very right. Intrinsic pathway means indoor game. Indoor game means you are playing what? You are playing table tennis. So once I'm playing table tennis, of course, I know that there will be increase in the value of APTT in these patients. What will happen to the value of prothrombin time or PT value in these patients? Of course, PT value is going to remain unaffected in these patients. That is going to be perfectly normal. Now, any patient who is going to be having this condition, There can be certain difficult questions which are going to be given to you or are asked to you in your clinical rounds as well. So whenever I'm talking about hemophilia A is what is also called as classical hemophilia. Classical hemophilia. It is going to be because of factor 8. Remember the 8 trick that I've told you? Hemophilia B is what is also called as Christmas disease. Christmas disease is seen because of factor 9 deficiency. Right? So whenever we're going to be talking about Christmas disease, please remember that you are going to be having a very good time at Christmas. You are going to be at your leisure best. Right? So you are playing, you are having a good time, you are partying, you are going to be having a great time. That is hemophilia B. So when majority of people are going to be having a great time, they are going to be having the best times of their lives. Hemophilia B, that is usually the Christmas festival. So please remember that that is going to be seen because of factor 9 deficiency. Hemophilia C is going to be the rarest type of hemophilia, but that is called by the name of Rosenthal's disease. And which is a clotting factor deficient in these patients? They are going to be having a deficiency of clotting factor number 11. Now, depending upon what is the level of the clotting factors, hemophilias are going to be either mild or they are moderate or they are severe. If a person is going to be having the value of clotting factors which is going to be around 40%, right, from around 5 to 40%, we still call it as mild hemophilia. Now that is something which is interesting, that you do not need to have 100% of the clotting factors for the proper functioning of the coagulation cascade. Even if you are going to be having 5 to 40%, still it is a mild disease. But if a person is going to be having in the range of 1 to 5%, it is called as moderate hemophilia. That means the bleeding is going to be relatively much more severe. But if the people are going to be having a deficiency of a clotting factor because of which the level of the clotting factors is going to be less than 1%, then it is given the name of severe hemophilia. And these are the patients who are going to be having more trouble simply because the lower is the factor level, the higher is the chance of bleeding, and therefore the more is the severity of hemophilia. So that is what we need to remember over here. So when I'm talking about hemophilias, they are example of disorders because of which my patient is going to be having a higher chance of bleeding. And all these hemophilias, A, B and C, are seen because of a problem at the level of the intrinsic pathway. So all these patients are going to be having an increase in the value of APTT. Now, what you need to remember over here is going to be a very, very important fact that if my patient is going to be having a history of bleeding, let us say a patient comes to you in the emergency because he is having the presence of a bleeding. So he is coming to in the ER because of bleeding. He is going to be having a test done and the test shows value of PT to be normal, value of APTT to be elevated. That means he is having hemophilia. So what will I do for these patients? I have to check out whether they are having hemophilia A, hemophilia B or hemophilia C. Classically, please remember, when a patient is going to be having hemophilia A, B or C and you want to differentiate it, you go for the estimation of factor levels in the blood. So serum factor levels are to be checked. If the person is having deficiency of factor 8, then obviously we will call it as hemophilia A. If he is having deficiency of factor 9, you will call it by the name of hemophilia B. If he is having deficiency of factor 11, you will call it by the name of hemophilia C. So that is the importance of knowing about the concept of hemophilia so far as the coagulation cascade is concerned. Another important fact that we need to remember over here is the coagulation cascade becomes very, very important in your knowledge of pharmacology. There are certain conditions in which the patients are going to be having high chances of clot formation. These conditions are given the name of hypercoagulable states. Higher chances of clot formation means hypercoagulable states. And in these conditions, what is the problem with the patients? The patients are going to be having thrombosis, high chances of clot formation. Now, in that situation, you want to decrease the chance of clot formation because if you are going to be having too much of clot formation, understand this fact, if you are going to be having too much of clot formation, why is that bad? Because this can compromise with the blood supply at the level of the heart. This can compromise with the blood supply at the level of the brain, or this can compromise with the blood supply at the level of any vital organ. So you are all familiar with conditions like, for example, myocardial infarction, for example, a condition like the presence of ischemic stroke, or for example, conditions in which patients are going to be having clot formation in their lower limbs, what is given the name of deep vein thrombosis. Now, in these conditions, you do not want your patient to have too much of clot formation. So what will you do? In such situations, you are going to be giving these patients a group of drugs, and these drugs are given the name of anticoagulant drugs. Anticoagulant drugs. The name gives you hint, friends. Drugs which are going to decrease the chances of clot formation, they are called as anticoagulant drugs. Now, whenever these drugs are being given, how will they work? They are going to be working by acting on either of the two pathways. Either they will inhibit the activity of extrinsic pathway or they will inhibit the activity of the intrinsic pathway. So when these drugs are being given, they interfere with the activity of the clotting factors, and that is how they are going to be useful for the purpose of anti-clot formation. But please remember, what is the importance of knowing about this fact? The importance of knowing about these fact is that these drugs are going to be acting by different mechanisms. Let us just first have a quick look at the examples of the anticoagulant drugs which are being used clinically very commonly. So we divide these drugs into two categories. One are the drugs which are going to be given by you very commonly because they are example of anticoagulant drugs which can be given by route number 1. That is going to be, they are drugs which are going to be given by the oral route. And the second can be example of drugs which are given by the parenteral route. That means they are injectable drugs. So whenever we are talking about oral anticoagulant drugs, one of the first category of drugs which has to be remembered by you are drugs which are going to act by inhibiting the enzyme vitamin K. Now understand, vitamin K inhibitor drugs are going to be having what action? Revise what we discussed in the earlier part of the video. Some clotting factors require vitamin K. What are the examples of these clotting factors? Factors 2, factor 7, factor 9 and factor 10. So if I'm going to be inhibiting vitamin K, then these clotting factors are going to become less in amount. And if they become less in amount, the chances of clot formation is going to be less. So whenever we are talking about drugs which are going to be vitamin K inhibitors, one of the very common group of drugs that we understand is warfarin, or with the drugs which are going to be given the name of the coumarin drugs. So dicumarol, acinocumarin, very importantly given drugs. And what is the mechanism of these drugs? These drugs are going to be acting by inhibiting or decreasing the activity of vitamin K. There are now special drugs available which can be given in the form of tablets or orally effective drugs which can be inhibiting factor 10A directly. These are drugs which are going to be given the name of rivaroxaban and apixaban. Rivaroxaban and apixaban. Then we have got drugs which are going to inhibit directly factor 2. They are given the name of direct thrombin inhibitors. And the examples of such drugs include a drug like zimelangatran and dabigatran. So clinically, all these drugs are being given very commonly, but at least at a basic level, you must always remember one example from each of these categories. So vitamin K inhibitors are the coumarin drugs like warfarin or acinocumarin, or we are talking about drugs which are direct thrombin inhibitors like the gatran drugs, so dabigatran or the zimelangatran, and factor 10 inhibitors, drugs which are going to be given the name of apixaban or rivaroxaban. Certain drugs which are going to be given by the injectable route or the parenteral route, as we call them as parenteral. You are not giving them by the oral route, you are giving them by the parenteral route. They can be acting by inhibiting two pathways. One possibility is that they directly inhibit thrombin. If they directly inhibit thrombin, then the drugs are going to be having the names like hirudin, or we are having a drug like argatroban, or we are having a drug like melagatran. So they are directly going to inhibit the thrombin. Or we have got drugs which are going to be acting indirectly. Very, very importantly tested in the exams as well as in the clinical rounds. Indirectly acting thrombin inhibitors. What will they do? They are going to act by increasing the activity of a molecule that is given the name of antithrombin. So you have a blood protein which is given the name of antithrombin. And as the name gives you a hint, friends, antithrombin means it's an example of a protein which is going to be working opposite to thrombin. So what will it do? It is not going to allow the activity of thrombin. So you are giving a medicine, you are giving a drug which is not going to inhibit thrombin directly, but it is going to increase the activity of antithrombin protein. So if you increase the activity of antithrombin protein, this antithrombin protein is going to decrease the activity of factor 2 or thrombin, and that is how it is going to be working in the patients. Now the example of the indirectly acting drugs include a drug that is going to be given the name of heparin, very important drug. Heparin is a big molecule. So this drug, which was earlier being given the name of a big molecule drug, was given the name of unfractionated heparin, UFH, unfractionated heparin. What we realized is that scientists discovered that a part of this drug can be very effective also. So they broke down the drug into a smaller fragment, and that smaller fragment is given the name of low molecular weight heparin. Smaller fragment is given the name of low molecular weight heparin. There are multiple examples of low molecular weight heparins, but the examples that you have to remember, at least one or two of them: enoxaparin. We have got a drug that is given the name of deltiparin. We have got a drug that is given the name of tinzaparin. From the low molecular weight heparin, we realized that there can be still ultra low molecular weight heparin, which can be working in some patients, and that particular drug is going to be given the name of fondaparinux. Fondaparinux. So please remember that heparin group of drugs are those group of drugs which are going to be acting by inhibiting the thrombin indirectly because they increase the activity of something like antithrombin molecule in the body. So these are drugs which are going to be given the name of anticoagulant drugs, very, very effective drugs for inhibiting the activity of the coagulation cascade. Now, please understand, when these drugs are being given, what will they do? They will inhibit the chances of clot formation. So the problem that we are going to be encountering with these drugs is that these drugs can be responsible for causing increase in the risk of a very important side effect. And what is the side effect which can be seen with these drugs? All these drugs can be responsible for causing bleeding in your patients. So when I'm talking about a drug called as warfarin, which is commonly given as an example of an oral anticoagulant drug, or I'm talking about a drug which is a parenteral drug to be remembered that is given the name of heparin, all these drugs can be responsible for increasing the chances of bleeding. Now, I do not want my patient to bleed. So typically what you need to be doing and knowing about over here is a simple knowledge, friends, that whenever you're going to be giving these drugs, you have to monitor the action of these drugs. For monitoring the activity of these drugs, we go to the basics, what we talked about earlier. We have to monitor them with the help of two pathways. And these pathways, as I shared with you earlier, were the two types of tests, PT and APTT. PT and APTT. Now, which particular drug is going to be useful for the monitoring of which pathway? Now, that is always a dilemma for most of the people. But I hope that you will be able to remember this after watching this particular video today. Whenever I'm going to be talking about a drug that is going to be given, a drug like warfarin. What is warfarin going to be doing? Warfarin inhibits the activity of vitamin K. To be specific, some of you may be having an idea. Warfarin decreases the activity of an enzyme that is vitamin K epoxide reductase. So it is going to interfere with the activity of vitamin K. Now, if you are going to be interfering with the activity of vitamin K, what will happen? The concentration of vitamin K dependent clotting factors is going to go down. And which are the factors which are having vitamin K dependence? Factors 2, factor 7, factor 9 and factor 10. If you are going to be inhibiting factors 2, 7, 9 and 10, their levels are going down. Which of these factors is typically going to be disappearing first? The factor which is going to run away first, that is typically factor 7. Now, if factor 7 is going to run away, I repeat my point, I am giving a drug like warfarin. And this particular drug is responsible for causing inhibition of vitamin K, and therefore the patient is going to be having the presence of vitamin K underactivity. So this situation is going to be characterized by patients having a decrease in the concentration of factors 2, 7, 9 and 10. Out of which I want to remember, factor 7 is going to be disappearing first. If factor 7 is going to be disappearing first, this drug warfarin is directly going to be affecting which pathway? It is going to be affecting the extrinsic pathway. The moment I am talking about warfarin affecting the extrinsic pathway, what will immediately come to your mind is which game is going to be affected? Table tennis or simply tennis? Of course, you know that if extrinsic pathway is affected, there is going to be a problem at the level of extrinsic pathway. So there is going to be an increase in the value of prothrombin time. So whenever I am going to be giving a drug like warfarin, I repeat my point, it is going to interfere with the activity of extrinsic pathway. So monitoring of warfarin has to be done with the help of PT. Prothrombin time has to be regularly monitored in these patients. A modified version of prothrombin time is what is being used in the clinics these days. That is given the name of INR. Modified version of prothrombin time is being used these days. It is given the name of INR, International Normalized Ratio. So warfarin monitoring is always done with the help of INR or International Normalized Ratio. On the other hand, if I'm talking about a drug like heparin, heparin is a drug which is going to be responsible for acting by indirect manner. What was the indirect manner? Heparin was a drug which was responsible for increasing the activity of antithrombin. So this particular drug typically is going to be responsible for decreasing the activity of factors 12, 11, 9. And whenever I'm talking about factors 12, 11, 9, it is going to be involving the intrinsic pathway. So simple thing is, heparin affects intrinsic pathway, warfarin affects extrinsic pathway. Heparin affects intrinsic pathway, warfarin affects extrinsic pathway. Therefore, any patient who has been given heparin, the monitoring of the intrinsic pathway becomes very crucial. And which is a parameter that is being used for monitoring of the intrinsic pathway? Yes, you know it right. The monitoring of the patients is going to be done with the help of a parameter that is APTT. So heparin monitoring is done with the help of APTT. Warfarin monitoring is done with the help of prothrombin time. That is what we need to remember so far as the clinical use of the anticoagulant drugs is concerned. So we must have an idea about the way the drugs are being used. We must have an idea about what is the important side effect of these drugs, something which can be very life-threatening as well, which is something like bleeding. And we need to remember the fact, how do we monitor the action of these drugs? Warfarin monitoring done with the help of PT or INR, and heparin monitoring is done with the help of APTT. That is what is the use of the anticoagulant drugs, right? So that is what we just wanted to have an idea so far as the action of the anticoagulant drugs was concerned. So what we have learned over today has been very, very crucial, 3 important facts. And that is what I always talk about whenever I'm going to be talking about the concept of revision with you friends, that first we learn about the normal physiological and role of the intrinsic and the extrinsic pathways. Then we talked about the example of pathological conditions where clotting factors can be deficient. And third, we talk about and link it with pharmacology, where we talk about the role of the different kinds of drugs which are going to be used so as to interfere with the activity of the coagulation cascade. Once you have done with watching this particular video, watch out the next video in which we are going to be having a discussion with respect to the important multiple choice type questions or the clinical scenarios which are going to be asked in the exam, in which questions pertaining to the coagulation cascade is going to be asked to you, right? So I hope your fear of the coagulation cascade is now going to be gone forever. If you felt that this particular video was pretty much useful to you, then all I can request to you over here is going to be a simple fact. Friends, I would request you to just like, share and subscribe the channel, because you are liking the channel, you are subscribing to the channel, and your encouragement means a lot to us. And this is what is going to be helping us in making more videos from the perspective of your particular usage. Also in the comment section, do let me know any other topics which you personally find difficult so that I can make it easier for you. I can help you integrate it with multiple subjects like physiology, like pathology, like medicine, like pharmacology, make things and life easier for you. As I say that again, just remind yourselves, let's simplify medicine. Let's make it easy. Thank you so much for watching this video and hope to see you in the next video very soon. Thank you.